Good evening, everyone. Thank you for joining us for tonight's International Dermatology Education Foundation Educational Series webinar. My name is Ashley with RBC Consultants, and tonight's title is The Latest Approved Indication for COSENTYX. As moderator this evening, we have Dr. Leon Kircik, who's president of this International Dermatology Education Foundation, clinical professor of dermatology at the Icahn School of Medicine at Mount Sinai in New York, Indiana Jones University Medical Center, Indianapolis, Indiana, and medical director of Physician Skincare, DermResearch, and Skin Sciences, all out of Louisville, Kentucky. As speaker this evening, we have Dr. Vivian Shi. She is Associate Professor, Director of Clinical Trials, and Director of the Hidradenitis Suppurativa Clinic, Department of Dermatology, University of Arkansas for Medical Sciences, an executive board member and treasurer for the Hidradenitis Suppurativa Foundation. We would like to thank our supporter this evening, Novartis, for making this educational event possible. Before we begin, some logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just click on the phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues, please submit your questions in the question pane on the right-hand side of your screen. And at the end of this webinar, a survey will pop up in your browser and it will also be emailed to you within 1 to 2 days. We would greatly appreciate it if you could fill in this short survey. And finally, within 1 to 2 days of the webinar, you will also receive a certificate of attendance. It will come to you via email. And again, we will have a live Q&A portion at the end of the presentation, so please submit your questions using the questions pane on the right-hand side of your screen. Now, without further ado, I would like to pass the floor virtually to Dr. Kircik.
Thank you, Ashley, and good evening, everyone. Greetings from Louisville, Kentucky, and thank you for joining us tonight on a very exciting topic. You know, we have heard about atopic derm, we have heard about psoriasis, but hidradenitis suppurativa is something that our patients suffer, and unfortunately, we did not have much until recently to treat them. So now we are glad that we have something new to talk about. And next slide, please. Just before we go, however, to our scheduled lecture, a couple of words about International Dermatology Education Foundation. As you know, it is a nonprofit organization whose principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And we have done this very successfully within the last couple of years through our webinars and some live programs in North America. But our live webinars have extended all over the world, including not only North America, South America, but also Asia, Southeast Asia, as well as Europe. So as you can see, those are a couple of our programs in the past. And tonight we're very lucky. Next slide, please. We are very lucky to have Dr. Vivian Shi from University of Arkansas, and she's going to talk to us about the latest approved indication for COSENTYX. Welcome and thank you. Here you go.
Thank you for the introduction. Good evening, everyone. It's a pleasure to be here. So greetings from Little Rock, Arkansas. As the introduction said, I run an HS clinic here, and we see mostly African-American women with early stage 2 and mostly 3. So we're really glad that finally we have another option, systemic option, to treat these people suffering from the disease. And let us get started. May I have the control of the slide again, please?
Yes, let me take it and give it back. All right, so go ahead and click in the center.
Okay. There we go. Just lagged a little bit. Okay, So the program title is to discover the data, and COSENTYX now approved for HS, and it's the first and only FDA-approved IL-17A antagonist. It's a biologic. So we'll take the next 35 minutes or so to look at some backgrounds of hidradenitis, the pathoetiology, and the burden that these people are suffering. Then we're going to move on to take a look at the clinical efficacy and safety data on COSENTYX, and we'll end on how to get patients started on COSENTYX. So like I said, we're going to start with the burdens of HS. And this is a really profound burden that affects every single aspects of their life, including education, mobility, personal life, and the overall mental health. It's definitely understudied. So about 15 years ago, HS is considered an orphan disease. It's so understudied. It's underdiagnosed. The average diagnosis from time of disease onset to actual diagnosis globally is estimated to be about 7 to 10 years. But I think many of us have seen patients who have lived with the disease for decades before ever even hearing about the word hidradenitis suppurativa. It's also undertreated. People can go years just on topical medications before they're even discussed or presented with an advanced treatment option. And 1 in 100 people worldwide is affected with this condition. But these are epidemiologic studies, so they're mostly done in westernized countries. There are many parts of the world where HS is understudied and underreported. So likely the global prevalence is much higher than what we think, according to disease studies. So we know it's a chronic condition. It's not just a skin condition. It's associated with many, many comorbidities in the body. Clinically, it's characterized by recurrent painful lesions. These can be nodules, abscesses, or what patients call boils, and tunnels, also known as sinus tracts. And it can affect every single part of the body that's hair-bearing, I guess, with the exception of the palms and soles. So anywhere is possible, not just the intertriginous areas. I've had people who come in having it on the scalp, behind the ears, even back of the thigh, things that aren't typically HS, and these are called ectopic areas. And this is a progressive disease. So it will go from just having papules to scarring. And when these scars coalesce, you'll see a diagram later, that causes irreversible skin damage. And this causes scarring and recurrent pain. And that is a substantial burden. Many of my patients come in a wheelchair with decreased mobility. They aren't able to work, and their financial status also are impacted. So almost all of the patients, according to many studies, so 97%, as you see here, experience physical pain. And these are not just nociceptive inflammatory pain. Over time, they develop neuropathic pain as well. So that is a very complicated disease. And that's why starting an advanced treatment like a biologic treatment prior to developing multiple irreversible tunnels and scarring is thought to be the key in improving the longitudinal outcome of these patients. And oftentimes I say there is a window of opportunity for us to capture these patients early on before they develop tunnels. As soon as they get scarring or very early moderate, you got to hit them hard with biologics in order to have a good outcome, because if untreated, they are going to progress and have comorbidities lifelong. So when a patient is biologic ready, and we can talk about this too, what does that mean to be biologic ready? They can achieve meaningful relief with COSENTYX, and this is approved in adults with moderate to severe hidradenitis suppurativa. So how do you define moderate to severe? Anytime when they have uncontrolled disease or scarring, you can essentially call them moderate. And so these are many patients, I think, in our day-to-day practice are eligible for systemic therapy, especially when they have failed topical therapy in first line or antibiotics. So we're going to take a closer look at COSENTYX. I joke around, but I think it's true. COSENTYX is kind of like a household name. There's a heritage coming from Novartis. It started with our 16 years of clinical trial experience with the drug. It's been on the market for over 8 years across multiple indications we'll see in the next slide. About 3.7 million people have been written a prescription of COSENTYX in the US alone, and Novartis has got a pretty good patient support program to help people get on the medicine and stay on the medicine long-term, because this is a chronic disease. So long-term maintenance therapy is very important. So about the history of COSENTYX, it started at 2015. It was initially approved for moderate to severe plaque psoriasis in adults. Then 2016, it was approved for psoriatic arthritis and ankylosing spondylitis AS. In 2020, it was then approved for non-radiographic axial spondyloarthritis in people with signs of objective inflammation. A year later, it was approved in pediatric patients with moderate to severe plaque psoriasis 6 years and older, and enthesitis-related arthritis in kids 4 years, older, and active juvenile psoriatic arthritis of kids 2 years and older. And the remaining of this discussion is going to focus on what happened in 2023. It was a very exciting time. I remember getting a call on Halloween Day, 2023, learning that COSENTYX has finally become an option for people with HS. So we talked about it's the only and first FDA-approved IL-17A antagonist. So what does that mean for people with HS? We're going to take a look at the mechanisms and how IL-17 is involved in causing HS. We now know through many studies that there is increased IL-17A level. It's a cytokine in both the lesional skin and also the perilesional normal appearing skin. So it's definitely an important player in inflammation and progression of HS. So you're going to see some simulated photo here representing HS lesions and how initial inciting events ultimately lead to progression. So follicular hyperkeratosis is the inciting event. This is what we understand so far. So the hair follicle, it's sticky. There's a lot of keratinocyte shedding. There's overproduction of oil gland that causes a microcomedone or a comedone. And over time, that builds up. It's like I tell people this kind of like a cottage cheese filled in a Ziploc bag. The bag eventually fills and gets so firm it pops or it leaks. And when it leaks, these contents that's not supposed to be in the interstitium of the skin it activates immune cells nearby. And these include multiple type of immune cells, including mast cells, macrophages, T cells, and neutrophils. These are the important lymphocytes and leukocyte players. And IL-17 is central. It's a central cytokine involved in activation of these immune cells and progression of the inflammation. So when you have a popped follicle, and then when you have adjacent ones doing the same thing, over time, the chronic inflammation is going to cause them to connect. And you'll see a tunnel that forms underneath the skin with a lot of scarring underneath. The body's constantly trying to clean this up, but has a dysregulated inflammation. So I always like to think of this as like a sewage pipe underneath the skin. It's filled with bacteria, dead skin, and inflammatory markers. This tunnel won't go away on its own, right? So a lot of times surgery is needed to combine with medical therapy, but we have to calm the inflammation and to prevent the progression of subsequent scarring in the same location and in distant sites. So we talked about IL-17. COSENTYX is a monoclonal antibody that specifically binds to interleukin 17A, which prevents the interaction of the cytokine type to its receptor, thus inhibiting the downstream inflammatory signal, improving HS and other diseases involved. Okay. We already talked about this. When we calm the IL-17A level, it's thought to reduce the signs and symptoms of HS by decreasing the inflammatory nodule counts, the abscess count, and also hopefully prevent the progression of the disease. So the patients will have more good days and less bad days. And if they were to get a bad day, those days are less bad in intensity. So next, we're going to take a look at the clinical trials that led to the approval of COSENTYX for HS. These are the Sinai trials, very cute name. So there are twin trials, Sunshine and Sunrise. So they're the largest ever phase 3 clinical trials programs for HS involving more than 1,000 people. So that's pretty impressive. All these people came across the world to make this happen. So in these two trials, we talked about they're randomized, double-blind, multi-center studies. Essentially every continent of the world had been covered and have patient enrolled. And it's assessed short-term efficacy and safety at 16 weeks and long-term efficacy and safety up to a year in adults with moderate to severe HS. So overall, a little bit less than 1,100 patients completed the study across nearly 220 sites worldwide. It took place between January 2019 and July 2022 over a span about a year and a half of time. So who were the patients that were involved? These were adults with moderate to severe HS. That's defined as at least 5 inflammatory lesions, such as abscesses or inflammatory nodules or more. They have to affect at least 2 distinct anatomical areas. So that means like left underarm and right underarm, or like right underarm and left groin. They must have a diagnosis of HS for at least 1 year prior to baseline and have to be on stable treatment with antibiotics. And if they had previous exposure to TNF inhibitor biologics, they are allowed to be in the study, which is really, it is very good inclusion criteria because many of our patients have been on TNF inhibitors, which has been approved for a few years now. So the exclusion criteria are people who have very severe disease with multiple fistulas greater than 20 or more, or if they have any other active disease that can interfere with assessment of hidradenitis. They can't be pregnant or breastfeeding. They can't have other inflammatory diseases such as, but not not limited to inflammatory bowel disease. So anyone with IBD are excluded from the study. And if they had prior exposure to any biologic therapy targeting IL-17A or F, or the IL-17 receptor, they're excluded as well. So these are the people, characteristics that participated in the trial. So we talked about these are twin trials. There's a 4-week screening period before baseline. These patients are randomized 1:1:1 to receive either COSENTYX 300 milligrams every 2 weeks. These are the purple colored graphs throughout the rest of the presentation, or COSENTYX 300 milligrams every 4 weeks. This is going to be in this pretty pink magenta color versus placebo that's going to be in the gray color moving forward. And that's period 1. And at the end of period 1, which is at 16 weeks, the primary endpoints was assessed. This is like their first report card. And the report card endpoint was HiSCR 50, which we're going to talk about a little bit. Essentially, it's 50% improvement in HS, and that's the most common industry standard to measure the efficacy of HS trials. There are a number of secondary endpoints that are assessed at week 16, including AN50, which is 50% reduction in abscesses and inflammatory nodule count, and the proportion of people with flares in their disease, and also skin pain, achieving a 30% reduction in their skin pain, or NRS 30 at week 16. These are among the people who have a baseline pain level of 3 or greater on a scale of 0 to 10. So that's period A. So that's short-term efficacy. Then we're going to take a look at period B, which is kind of looking at the long-term efficacy from week 16 all the way through week 52. So that's, a whole year of data. And people who were initially on their active drug will stay within the same assignment. But people who were initially on the placebo group, they will get re-randomized to either receive 300 milligrams every 2 weeks or 300 milligrams every 4 weeks. And then at the end of period 2, which is 52 weeks, another set of endpoints were assessed here. And these were pre-specified exploratory endpoints at 1 year. They're HiSCR 50, HiSCR 75, HiSCR 90, and HiSCR 100. You can see the bars just get higher and higher. To have complete clearance is one of the endpoints here, which is HiSCR 100. They're also assessing at 1 year AN50, the proportion of people having flares and skin pain, as well as Dermatology Life Quality Index, which is a 10 questionnaire for the patient to assess how much HS affects their daily life, including their activities, social life, and also emotional state. So these are the Sunny trial designs. Let's take a look at the patient baseline characteristics. They are adults, kind of broken down evenly between female and male. Most of them, over half of them, are overweight at 90 kilo or greater. Most of them are Caucasians, but we also have a good mix of African Americans and Asians, which is important because we know HS commonly affects people of color. Breaking down on the disease characteristics at baseline, we can see that there is a pretty even breakdown between Sunshine and Sunrise. A little bit higher proportion of people in Hurley 2 stage than Hurley 3. I want to just kind of point to your attention. This might explain some of the results you will see later between the Q2 week and Q4 week data, is that in these trials, especially in Sunrise, the proportion of people who are more severe or Hurley 3 is actually higher in the Q2W group here. So just keep that in mind as we're seeing the data later on. So about 40% of these people had previous surgeries for HS, and many of them had previous exposures to TNF inhibitors and systemic antibiotics as well. I want to just bring your attention to call out that nearly a quarter of them in these study trials were previously on an anti-TNF alpha biologic, which kind of mimics the general, like, real life participant, the patients that we see. Many of them have been biologic eligible and have already been on the first biologic that's been approved for HS. Makes sense. So let's take a look at the data, efficacy data for week 16. The primary endpoint, again, is HiSCR 50, which is defined as at least 50% reduction in abscesses, inflammatory nodules compared to baseline, as well as no increase in the number of abscesses and draining fistulas compared to baseline. So these data that I will tell you next are for the 300 milligrams every 4 weeks. So in both trials, about 31 to 42% of people achieved HiSCR 50 at week 16. Next, we're going to take a look at some pooled data. So this is combining the data for Sunrise and Sunshine, looking at HiSCR 50. You can see that you see my arrow here. The colored graph here is the active arm, and then the grayish colors in the placebo arm. You can see that the two sets of curves kind of separate pretty early on in the trial, as early as week 4. Again, these are not primary preset timeframes, so we can't really comment on clinical statistical significance. But you can see at the end of 16 weeks, pretty similar data for the Q2 week and Q4 week. About 45% reduction, people reached HiSCR compared to about 32 to 35% in the placebo arm. Next, we're going to take a look at the 1-year longitudinal data. You can see that people who initially were in the active arm continued to improve and stayed improved throughout the 1-week period. And people who were initially in the placebo arm, as soon as they were switched to active drug, they go boom. They start to get better, and their efficacy is maintained throughout the entire year as well. And at the 1 year, you can see that about 60% in the active arm, initially the first group that got active drug all throughout, achieved HiSCR 50, compared to the switchers, like the people who were initially in placebo then switched to active arm. The data is a little bit lower, about 51, 52%, but it's still pretty impressive data. So you can see improvement throughout the 1 year, regardless whether they had previous biologic exposure as well. So people who were previously exposed to TNF inhibitors responded pretty well. So 83% of people on COSENTYX did not form any new draining tunnel at 1 year, and that calls home on the importance of preventing progression in these patients, and COSENTYX have shown that most of the patients have had that benefit. Now you're seeing the exploratory endpoints at 1 year. For people who initially reached HiSCR 50, so these are responders looking at how they did after 1 year, for both trials at HiSCR 75, HiSCR 90, and HiSCR 100. You can see that even when the stringent endpoints increase, it's getting harder and harder to reach these endpoints, but still a good portion of people still who reached HiSCR stayed as a responder throughout. And you can see that we talked about, you may wonder, oh, you know, how come the Q4 week did a little bit better than the Q2 week looking at these data? But, you know, I told you that the baseline disease characteristics on how the Hurley 2 and 3s were distributed was a little bit uneven, so that may explain some of the difference you see between Q4 and Q2 week dosing. But nevertheless, we can say that on this graph, regardless of the dosing you're getting, right, Q2 or Q4 week, you will improve throughout 1 year if you were a responder initially at week 16. So this is really pretty data in my opinion. Okay, so we already talked about treating COSENTYX can help our patients achieve long-lasting relief at week 16 and also throughout 1 year period. But the results can also be seen very early on at week 2. Keep in mind that this is not an initial endpoint, so we can't really talk about statistical significance, but I wanted to bring your attention to early responders too. So this another secondary endpoint that's assessed at week 16 is AN50, so at least 50% reduction on just abscesses and inflammatory nodules with no inclusion of any fistula. So this is a simulated image, but I wanted to kind of give you an idea about what it means to reach AN50. So kind of a baseline of axilla with multiple inflammatory nodules and some abscesses. So if you were to reach AN50, you'll have 50% reduction in the number of these lesions, like what you see here. Okay, with that in mind, we'll take a look at the efficacy data for AN50 in these trials. About 51 to 52% at week 16 reached AN50. So that's pretty impressive. You tell people, okay, you're going to start this biologic injection after 4 months, sinus tracts aside, but your bumps and boils, you'll have 50% improvement. And that, if you're the average individual, 50% of you is going to get this result. And I think patients can be very happy. I mean, they're used to living with these boils intermittently without much improvement and actually progressing too. So now we're going to look at AN50 throughout 1 year. This is a very similar graph to HiSCR 50, but the data is even more impressive. It's about 71% of the patients on COSENTYX reached AN50 at 1 year. And then you can see the people who were initially in the placebo then switched to active arm improved as much as well. So very good. We can tell people that your AN count is going to continue to improve throughout the year. It's not going to dip, and you're going to maintain that response too. So next, we're going to look at flares. Patients with these chronic inflammatory disease are living in fear all the time, worrying when they're going to have the next flare. They can be in a very special event, and a big boil is going to come up, and it's going to pop on their dress. So this anticipatory anxiety for the flare, in my, many patients tell me that it drives, it's glooming over their life. So we'll see how COSENTYX can help these patients reduce their flare. This is looking at, excuse me, going back a little bit here. So you can see here that about 75% of the people had reduced flare at week 16, and flare is commonly defined in HS trial as 25% or greater increase in the abscesses inflammatory nodule count, and at least a minimum increase of 2 abscesses and inflammatory nodule compared to baseline. So it's not just your random coming a boil here and there that they call the office. You must hit this criteria in order to be considered a flare. And so most 2/3 of the people had reduced flare as early as week 16, okay? Next, you can see also here looking at 0 flare. So it's not just reduced flare, but looking at no flare at all. So 78% of patients on medicine have reported 0 flare at 1 year. So that's pretty impressive longitudinal data to have to live with unpredictable flare at any setting to like most being flare free. I think that's profound and really offers a different outlook on their disease and their quality of life. Okay, so skin pain, we saw in the initial slides, most of the patients will report physical pain. And COSENTYX have shown that it can reduce skin pain at week 16, and this improvement is observed throughout 1 year, and people continue to have pain reduction then. And 70% of people with moderate to severe skin pain at baseline, that's usually 7 or more in the ANS scale, have reported that their pain gone down to mild or no pain at all in 1 year. Next, we're going to take a look at the quality of life improvement. These are that 10 questionnaire that's pretty sensitive, in my opinion, to measure how the disease is affecting their life. And we will look at the week 16 data, which you can see that people who are on the active drug did much better in their pooled DLQI response at week 16 compared to placebo, and similar trend is seen even at week 52. Okay, so the improvement of quality of life in these trials were defined as at least 5-point reduction at their DLQI. And so the most important items that our patients talk about are their leisurely activities, their symptoms from their disease, and their emotional state, as well as personal relationships and intimacy. So not only that they look better, they feel better, they're living life fuller. So we're looking at COSENTYX. People on COSENTYX can experience really fast results as early as 2 weeks, and long-lasting results as you've seen in the 1 year data. And they have decreased number of lesion count by half, that's HiSCR 50, with no progression defined by no increase in permanent draining sinus tracts as well. So 1 year, you also saw these improvement. 75% had 50% or more improvement in their lesion counts. Over 80% had no new draining sinus tunnels. Nearly 80% had no flares, and 70% started to, who started with moderate to severe pain, reported little to no pain. And many people who were observed to have improvement in health-related quality of life. So this is a global improvement in a patient with HS. And I think one of the most sensitive things I see when they come back is that their DLQI really went down, but for the first time, they're no longer wearing black. Because you see, when you take care of enough HS patients, everyone is wearing black because they're afraid of drainage happening at any time. And as they're on the right treatment, everybody's shades of their outfit start to turn very light. And that was a really gratifying moment for me to be, to direct in HS clinics, that their clothing shades are getting lighter and lighter over time. So I think it's kind of funny, but really gratifying. Okay, we talked about efficacy. Now, how safe is this in people with HS? We'll look at the adverse events of interest and overall. Okay, so we know that COSENTYX has been around for a long time, and I can say globally, there's no surprise AE that came up in the HS trials that we don't already know about in our, as derm providers, in our psoriasis patients. So this is the safety confuso chart, really busy. At week 16, you can see that there are no deaths, thank goodness, during the first 16 weeks. Here's the sunshine trial and the sunrise trial. And then we have the Q4, Q2, and placebo divided like that. There is a increase in adverse event of special interest, such as infections and infestations, with fungal infections and candidiasis being the most common, as what we're already seeing in the other indications for COSENTYX. That was not a surprise to us. We will also see here that there is one case in the sunrise Q4 and one case in the Q2 for new onset IBD, so one Crohn's and one ulcerative colitis. But I'm going to have your slide for you to put perspective into this IBD in people with HS and people who are treated with COSENTYX. Now, you just saw the week 16 data. Now it's the 1 year data. Not much in things that came up, thank goodness. You have a couple of deaths here. One of them, I believe, was an MI in a patient with aortic stenosis, and then a couple here, it was a death from gastric bleed from taking also a lot of ibuprofen too. So similar information you see for the infections and fungal infections here, as you would expect with the COSENTYX trials, and similar data here, one more or two more of the new ones at IBD at 1 year. Still pretty low in incidence. Next, I'm going to put perspective for you of how IBD is in the general population. So remind you, in the Sinai trials, in over 1,000 patients, less than 0.3% incident of new onset IBD in people were treated with COSENTYX. And I wanted to put that into perspective of what known epidemiologic study shows. The prevalence of IBD in the general population is 1.3%, and the prevalence of IBD in people with HS is 3.3%. So there's an increase in the risk of IBD in people with HS. But both of these populations have higher incidence than people who received COSENTYX in the Sinai trial overall. So just wanted to keep that in mind. There were incidents of IBD but in the trials, but still lower than the general population and in the general population with HS. Okay. So this is kind of like looking at the high level view for the clinical profile. We know that COSENTYX has been around for a long time. There's no box warning for COSENTYX. In fact, there's no required routine lab monitoring during treatments. It's recommended, however, to evaluate our patients for TB before starting treatment. And there's no trend towards increased adverse event incidence for the rate of IBD, candidiasis, a major cardiovascular event, or malignancy through the 5-year data. Sorry, my slides are a little bit lagging. This is kind of the package insert safety information here. I'm not going to read every one of them to you, but I wanted to call out about the inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease. People who are on the Q2 week did have a higher incidence in these trials of IBD compared to people who are on the Q4 weeks. And then, I'm sorry, the slides keeps on going back and forth here and lagging. And then you will see that there are people who developed eczematous reactions from the injection. It ranges from a small patch to people even with erythroderma. So just keep in mind that to look out for that when you're when a patient who's treated with COSENTYX for any indication when an eczematous eruption happens. We want to evaluate for TB before starting COSENTYX. In my institution, that's a quantiferin gold. So we already talked about this slide. I'm going to advance forward if you'll let me, if the system will let me. So hypersensitivity reaction, like many systemic medications you've seen in package insert, there has been reported anaphylaxis in cases of urticaria occurring. One thing to keep in mind is that COSENTYX now come in different via like pens, injection pens. So one of them is a sensor-ready pen, and then there's the pre-filled syringe. We've used that for many years. Those two injection devices have natural latex rubber in it. So for people who are latex sensitive, you may have an allergic reaction. But that being said, the safety use of the COSENTYX sensor-ready pen or the pre-filled syringe in latex-sensitive individuals hasn't really been studied. In terms of immunization, it's recommended that they are up to date on all their age-appropriate immunizations according to the immunization guidelines, and to avoid any live vaccines on people who are treated with COSENTYX. And the most common adverse reaction, as we see in many systemic drugs in dermatology, are nasopharyngitis, diarrhea, and URIs. And these happen in greater than 1% of the population in this package insert here. Next, we're going to briefly talk about, now you identified a patient who is biologic ready. You now learn the efficacy data for COSENTYX, and now you know how safe it is. How do we get people started? And so I get people start on the Uno Ready pen. It's the newest injection device for COSENTYX. You will see that that's the one without the latex rubber. Okay, so the Uno Ready pen comes in 300 milligrams per syringe, and that's one weekly injection loading dose for 5 weeks. And then after that, you just get, for HS patients, you get one injection every 4 weeks for maintenance dosing. Now, in smaller fonts here, but I think it's the most important part of the slide, is that once you get a people on maintenance dose at every 4 weeks, you need to assess them to see how they're responding. If they're responding not adequately, then that's a shared decision discussion to have the patient. Consider increasing their dose to 300 milligrams every 2 weeks to get better efficacy. And there's no strict criteria on how you determine how they respond. You don't have to hit a certain point. It is a clinician's judgment and a decision shared with the patient to increase the dose to every frequency to every other week. So you can see here, this is the Uno Ready pen. It's a single injection auto injector with no natural rubber latex, and it's a convenient and self-administration. So 98%, almost all the patients reported no pain at the injection site, and this is a study done in patients with moderate to severe psoriasis on the skin. And just a kind of a side note, if you have a patient who's not on the Uno Ready, let's say they're on the sensor ready, or they're in the pre-filled syringe, you may have to fill out another prior auth in order to get them on the Uno pen. So COSENTYX is covered as the first or second line biologic in HS across private insurance, Medicaid, and Medicare. And so many of my patients are the latter. It's good to know that they're still the first or second line for these payers. Okay, so here's the access slide. So there's the Cover Until You Covered program where patients with commercial insurance, if they're qualified or if they're denied, then they can get up to 2 years of free drug. There's a copay card if you're commercially insured and you're approved, but the copay is too expensive, you can pay $0, and 94% of the enrollees in this program actually pay nothing out of pocket. And there's this Access and Reimbursement Manager program where they help people navigate how to get their medicine covered. And they're the Ready Set COSENTYX program where they have these great resources to help people get started, help our office get patients started. And they have pamphlets, injection resources, and also even dummies. So my pharmacist in my institution use these resources to introduce the medicine, to train them and help them continue to be on the medicine. Okay, so we're getting towards the very end here. So how do we help patients with HS find symptom relief COSENTYX? I still say the most important things to identify these patients early and start them early before irreversible damage really covers every part of their involved area. And that will really limit the progression and disability long-term sequelae reduction. So we know that in COSENTYX, the fast result is seen pretty early as week 2. We see the primary endpoints, HiSCR 50, along with other secondary endpoints at week 16. They can be reduced by half with no increase in draining tunnels, which is limiting the progression of the disease. It's got a well-studied clinical profile across multiple indications. It's like a household item. We've been giving COSENTYX for many years for psoriasis, and now we have coverage for private insurance and federal payers as well. So there's a QR code here if you want more information on COSENTYX and how to get them started. And with that, I will end the presentation portion of this program, and I'll give the floor back to Dr. Kircik to let us know what kind of questions came in.
Thank you so much for that amazing lecture. I learned a lot. I hope so does everybody else in the audience. So we have a lot of questions. We had a lot of people online, and unfortunately, we won't be able to answer all of them, but I'll go from the couple of the important ones. One, I think somebody wants to know a little bit more about the flare prevention. It's been always an important point, right? It's great to get the disease treated, or I should say controlled, but how far was that flare prevention? Can you a little bit more elaborate on it?
Yeah, so I think this question may be referring to how in general can we prevent flare in people with HS, right? So I think we've learned a lot from the world of psoriasis and atopic dermatitis is to be proactive about it. I always think that it's good to recognize your flares so you know how to prevent it. If you don't recognize your flares, you don't know how to prevent it. So keeping a really good diary is important. And historically, we've all seen patients who come in with this giant binder, multiple photos, and they have all these like charts and whatnot. And that was cumbersome for us to know their history. But now there's an app for HS. It's called the Papaya. It's available on iOS and will be available on Android in the next month or so. So people can download that. It's a one-step shop to record their symptoms, their potential triggers, document their flares, and how medication had improved them. They can actually take photos of individual lesions to match that, and also has a reports section to help us providers see how they did in between the visits. So that's really helped my patients recognize their flare, because they might not know it's like, say, the cotton candy they ate 2 weeks ago, but if you document these, it's there as a biofeedback and black and white showing this. But I can't stress the importance of lifestyle modifications in HS, and we all heard about diet. Yes, it is true, diet studies are hard to do, but I have so many patients saying that if I really moderately limit my dairy and sugary and American diet intake, it decreases. Everybody flares during Thanksgiving because the diet changes. And also strategic selection of their undergarment can also do the same thing. The thing that I've been having people do more recently is kind of like the Body Glide silicone rub-on for intertriginous areas when they're doing their exercises. So it's less rubbing. You may have seen this for many years before they actually had the Body Glides for athletes, but for women who wear high heels or men who wear high heels, they have these silicone rub-ons to prevent shaving. So that's been really helpful for patients. So these little lifestyle modifications is so important in preventing flares.
Thank you so much. That's really good information. Now, a related question to the previous one is the long-term data, right? Can you elaborate a little bit on the long-term data and how were the statistical analysis done?
So I'm not exactly sure what this person is referring to about long-term data, but the long-term data, what you see is at 1 year. But most trials, and including the COSENTYX trials, do not stop at 1 year. We need post-marketing studies. So they're, FDA actually mandates post-marketing studies. We wanted to, continue these patients on drug and see how they do at 3 years, 5 years. So perhaps next year when I give you this talk, or as you progress, you'll see 2-year data, 3-year data, and you will see the AEs numbers will go up because it's been around for longer, and the patient year is going to go up because we have more experience with this drug. Yeah. But that's important for us to see long-term safety. And a lot of times we know that safety signals don't come up during the first year, perhaps. We hope not, but that will take time. The other thing we'll see is also real life experience, how, because trials are very controlled environment, they have to fit a certain mold, but we know that HS patients don't follow the textbook. So real life data is also going to show us a lot of information too. But in terms of statistical analysis, there's different way to look at it. The most stringent one is non-responder imputation. So anybody who missed a trial or had a flare and needed rescue medicines according to protocol, when they do this type of very stringent analysis, they're considered non-responders. So they just drop off the efficacy data. So you will see as you're looking at these data throughout the COSENTYX long-term data that is what you will see, and that's compared to baseline, of course.
That's great info. Now I have an interesting question. Is COSENTYX a risk for reactivation of latent TB?
Well, if you want to be very big nerds together, we know that IL-17A specifically is not really involved in TB reactivation or fighting off TB. TNF though, right, on the other hand is. So yeah. When one is infected with TB or one have latent TB, you read on the x-ray, oh, granuloma, X, Y, and Z. So that walling off of the TB infection and forming that granuloma, inflammatory sac, if you would, requires TNF. And when you have a TNF inhibitor, that disinhibits the walling of it. So there's a higher risk in TNF inhibitor patients to have reactive TB or even disseminated TB. It's less so mechanistically as a problem for IL-17, especially IL-17A, but nevertheless, the FDA recommends, and many of your payers will recommend that a routine TB screening.
Is another one, this is an interesting question too, is dose escalation allowed in the studies? And if so, how do you increase your patients in real life?
Yeah, so trials are a little black and white. We have to follow the protocol. The design of the protocol is that when they are when they're randomized to either Q2 week or Q4 week, they stay with that within the first 16 weeks. The only group that had any change in their dose is that initial placebo group that got re-randomized to either Q4 to Q2 weeks. So dose escalation is not part of this trial, fortunately or unfortunately. And I think in real life we do a ton of those escalations. We do this for our oral JAK inhibitors a lot, right? And so in my personal experience, those escalations does improve people with HS. And I typically, in my personal opinion, I will give them about 12 weeks, see them back, talk about, because by then they will have already been on the maintenance dose for a couple months now. And that's enough time for me to see if they're good long-term on every 4 weeks. If they're not where they want to be, that's a real discussion to think about increasing the frequency to every 2 weeks.
That's yeah, that's really a good way of looking at it. I also always follow the sort of the protocol, you know, how long to wait to increase or change or switch people, because that's why the studies are done, right? Even though
Yep,
real
absolutely.
life is different and our patients are impatient, unfortunately. But that brings up, and it's a very relevant question of what we're talking. How do you consult your patients? You know, how do you start the conversation going to biologics versus something else? And you also brought up, I think, the diet and the lifestyle changes. How do you do that?
Yes. So, gosh, this is like a long conversation, right? My HS visits are sometimes 30, 40 minutes, and thankfully I have the luxury to do
Yeah.
so. But I think overall, it's the roadmap that we need to show them. The analogy I give is a football team. You have multiple players, each having a position. But the quarterback medicine, if you're eligible, is going to be your biologic medicine, whichever one it would be. But a quarterback, an MVP alone, is not able to win the game for your team. You must have other positions, right? So you must have your topical antibiotic, your lifestyle modifications, perhaps even oral antibiotics and surgery. All of these come together as the synergistic role to achieve the most optimal outcome. I would say I tell my residents, don't mess around too much. If they've done topicals, they've done oral antibiotics, and you've tried lifestyle modifications and maybe given them some metabolic tune-up or hormonal tune-up in women, and when they come back in 12 weeks, they're not at least 25% better, or if they already have sinus tracts, let's go to advanced treatment. I think one of the hardest conversation is still, at least in my population, about going from pills to injectables. But I would also say, you know, it's actually a safer way to deliver medicine, because when you inject it through the skin, you actually bypass the liver and kidney and all that thing. So it's actually the safer way to get to where things needs to be.
That's great. And I think there's a question about IBD, and you really did a very nice. You put it in a context about the IBD general population, HS population. We already know psoriasis population, and then the risk of the IL-17. So in this case, COSENTYX. Can you elaborate on that a little bit more?
Yeah, so if you look at the comorbidities associated with HS, IBD is there. People's got 3 to 5-fold increase in IBD, and that is real. And one thing I just urge everyone to think about as they're looking at, quote, HS in the perineum, perianal area, so like the underwear area, if they have lesions that just look off, or if they have knife-like ulcerations, those are the key words. Got to think about cutaneous Crohn's. And if you have a doubt, send them to a GI, get them scoped. And sometimes with Crohn's, you can have anywhere in the GI tract being involved. A colonoscopy is not enough, and they have many ways to reach every part of the digestive tract. So if you have a strong hunch, and then there's questionnaires, you can always look them up to screen for IBD. If those questionnaires fit the criteria, have a low threshold of referring to GI. And of course, if they're diagnosed with active IBD, don't start an IL-17 inhibitor, preferably. But if they don't have existing IBD, you can see the data here that it doesn't have a higher incidence of either IBD than the general population, even in compared to HS patients who have, you know, a higher risk. So, you know, the general population is like 1.3% of having IBD, and the HS population is 3.3%. So it's like about 3-fold increase. So we should screen for that.
So this question always comes up: how do you handle the family history of IBD? It's always, you know, it's not black and white.
I'm sorry, how do I handle the what of IBD?
Family history.
That is always tough. To me, it's
Yeah.
a personal history of IBD. Family history is not a contraindication, right, to start an IL-17 blocker. And of course, when I start somebody who just have a strong family history, I keep them on the symptom questionnaire all the time. If they have any new onset abdominal symptoms, irregular stool patterns or colors, I'm the first one they call, and then they're going to go to their PCP to get checked out.
And I think we have one more question, final. How do you handle COVID vaccinations?
Oh, well, they should get their COVID vaccine. That's my medical and personal opinion. If they can get up to date, great. I wouldn't wait 2-3 months for immunogenesis. Okay, let's just be real here. You see that it says, get up to date, don't do active, live virus vaccines. I just want to put into context, it's not necessarily we know something bad is going to happen if you get a live vaccine or, your nucleic acid vaccine. It just hasn't been studied, right? The unknown is what is going to happen if you get on COSENTYX and you get a vaccine. But the known is COVID is bad, flu is bad. So I will always go with the known. Yeah.
Yeah. I mean, none of the COVID vaccines are live, so it's not, they're all
That's correct.
not live, so it's okay.
Yeah, and
live
in my
vaccines are
patient,
contraindicated.
exactly. I mean, in my population, it takes a little longer for any specialty drug to get approved. Most of them are federal players, so that 90-day waiting period of failures, I say go ahead. You're going to start a biologic. Go ahead and get your vaccine now. That's enough time to mount an immune response.
Very well. We are on the clock here. I thank you so much for a wonderful presentation. We all learned a lot, and hopefully we'll see you next year back with more data, right? So I thank everyone and have a good night. And please join us on February 6th for another program with IDEF, International Dermatology Education Foundation, where we will have Dr. James Del Raso, and he's going to talk to us on acne vulgaris. Thank you, everyone, and have a good evening. Thank you for joining us. I'm so incompetent. I can't even close.